Good evening, everyone. Welcome to the seventh episode of Trinity Talk, entitled SARS-CoV-2 to NAT or Not, exploring nucleic acid and antibody testing as diagnostic methods for COVID-19. My name is Nell Sarmiento, and I welcome you to a night of informative discussions on the current updates in SARS-CoV-2 testing and COVID-19 triage, featuring Trinity University of Asia's very own faculty frontliners. And now, to officially begin our webinar, let us pause for a while for a devotion. Dear God, we thank you for tonight. Thank you for the opportunity that you have given us to learn. We thank you for the gift of knowledge and for blessing us with people who are willing to share their talents for the learning of everyone. We lift up to you this webinar, and we pray that everyone who are watching will be blessed through it. We praise and thank you for everything. Amen. Followed by the national anthem.
Mga kababayan, ang pambansang awit ng Pilipinas.
Kayang magiliw, telas ng sinangalan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, tuyag ka ng magiting, sa mandulupin, di ka pasisingil, sa dagatang tutok sa simoy at sa langit kong bagaw, ay hinatang tulad, awit sa paglayang minamahal, ang isang ng matawad mo'y tagumpay na nagtitindig, ang bituin at araw niya kailan pang ay di magtitindig, luman ang araw ng buwan, hangin pagsinta, buhay langit sa piling mo. Ang inigaya ng pagkay mga aking, ang mamatay ng dahil sa'yo.
To formally start the webinar, please welcome the Vice President for Academic Affairs of the Trinity University of Asia, Dr. Gisela de Asas Luna.
Thank you, Nell. This is my third Zoom meeting now, and you'll just have to forgive me if I leave after because I'm having digital stress already. This is the reason why I decided to hide myself first, but I was told to open my mic and open my video, so sige. But anyway, good evening to all the participants. I said across disciplines because I hear that there are people not only coming from the medical technology, but from all other health science disciplines. And across the globe, I think, as far as I can understand. So welcome to this seminar, your SARS-CoV-2 to NAT or Not. And my congratulations, of course, to the College of Medical Technology, led by your very energetic and hyperactive Dean, Dr. Maria Teresa Rodriguez. Congratulations to you for starting this. And I hope you're all well, strong, and healthy, and keeping yourself safe. These are extraordinary times, and you will all agree that when we got into this situation, we thought that this was going to be just for a short while. We were mistaken. We didn't expect it could last this long, with consequent devastating effects in all aspects of our lives. So our life and our activities have been filled with webinars that are contextual to the times. And this is just one of those webinars where this is very much relevant to what we are experiencing right now and very much controversial. Is it not or not? So what you'll be listening to and the sharing of experiences and discussion through your speakers could probably stimulate the emergence of maybe new ideas or concepts or new perspectives, especially with such speakers who are probably well known in what they do, and you have your panel discussions as well. So I'm hoping that this webinar will not just increase your knowledge, because I think that's one of the purposes here, but more than anything, it should widen your collegial circle of collegial connections, and therefore become a bigger circle of exchanges of information and practices. I hope this will not just stop here. You need to sustain this. I hope also that you enjoy your interaction, and may this be really a worthwhile and fruitful one, and for everyone. And everybody, just a reminder, if you have nothing else to do and go outside, you don't need to go outside, just stay at home and be safe. And remember your health protocols. So good evening, everyone, and enjoy your night and enjoy this webinar. Stay safe as always. Thank you very much.
Thank you, Dr. Luna, for that very encouraging message. Truly, the year 2020 has been greatly affected by the COVID-19 pandemic that is caused by SARS-CoV-2. Until now, SARS-CoV-2 has been constantly changing the way we understand it. So to give us the rationale for this webinar, we have the Dean of the College of Medical Technology and Program Head of the Master of Science in Medical Technology Department of the Graduate School, Dr. Maria Teresa Rodriguez.
Thank you so much, Ma'am Nel Sarmiento. Good evening to all. The title of the webinar implies that there is a nucleic acid test that is commonly used in the detection of the severe acute respiratory syndrome, coronavirus 2 or SARS-CoV-2, the agent of the COVID-19. Likewise, the webinar also tells us that there is another NAT, which was mentioned by VP Dr. Luna, which is NOT, which means that is the usual question of the people posted on the table, discussion table of the medical technologists, as well as our medical doctors on, do we have other tests aside from the nucleic acid test, which could assist in the diagnosis of the COVID-19 and which would greatly assist our clinicians. So the very purpose of this conversation is for our speakers who are all faculty of the College of Medical Technology. They will actually share their experiences as frontliners, their observations and their challenges on handling patients with COVID-19 as well as suspected patients, as well as handling the different biological samples. Likewise, our panel of discussants would share some clarifications on very salient points. So this evening, we would like to invite all of you to listen and also reflect on the discussions of the speakers, as well as let us bring with us the lessons, as well as the knowledge that would be given by our speakers. In behalf of the administrators of the Trinity University of Asia, led by our university president, Dr. Wilfred Chu, our vice president for academic affairs, Dr. Gisela D. Luna, our vice president for administration and finance, Mrs. Leonora Enhente, and our dean of the graduate school, Dr. Juliet Bukoy. Thank you so much to all the registrants across the globe. Thank you so much to all of you who are listening right now in Facebook Live. And our highest salutations and respect to all the frontliners across the globe who are consistently sharing themselves and who are consistently upholding our oath to God and humanity. And that is by serving the sick, and most importantly, by sharing all our skills with our medical doctors. Thank you so much. Good evening to all, and God bless us.
Thank you, Dr. Rodriguez. Allow me now to introduce to you our moderator for tonight. She is Dr. Jean Joanne D. Polido, a faculty of the Trinity University of Asia College of Medical Technology. She is also a lawyer and is currently an affiliate of the Polido and Tiamson Law Offices. Let us all welcome Dr. Polido.
Thank you, Professor Nel Sarmiento. Good evening to all the speakers, panels, esteemed guests, and most especially the participants of the first ever webinar of the College of Medical Technology, Trinity University of Asia. Before I introduce the first speaker, let me remind everyone of some guidelines as we go through tonight's webinar. First, kindly turn off your microphones. Turn your microphones to mute so as to avoid interrupting the speaker. Second, since the posting of the official webinar poster, we have received questions from which we selected a few that will be answered later. Thus, should you wish to ask more, and if our time permits us, kindly direct the same to the comment section below, and they will all be answered later at the end of the session. And most importantly, enjoy the learning, because learning never stops. Let me now introduce you to our first speaker. Our first speaker is Professor Janina Camille G. Buliago. She is currently an assistant professor of the Trinity University of Asia, College of Medical Technology. At present, she is a frontliner who is serving as a volunteer medical technologist of the Philippine Red Cross's Molecular Laboratory. Please all welcome Professor Buliago.
A pleasant evening to everyone. I would like to thank Trinity University of Asia, the College of Medical Technology, and the Graduate School Master of Science in Medical Technology Department for giving me this opportunity to be part of this webinar. I'm ecstatic to share my experience on a very timely topic. One of mankind's strongest emotion is fear, and our greatest kind of fear is fear of the unknown. Currently, we are facing a disease in which we have limited knowledge. This has created a global health crisis that has had a deep impact on the way we perceive our world and our everyday lives. My presentation will include a timeline of notable viral respiratory outbreaks, introduction to COVID-19, focusing on the epidemiological and geographical history, and lastly, an update on the current situation of COVID-19 in the Philippines and globally. The world has experienced its fair share of disease outbreaks, may it be an endemic, an epidemic, or worse, a pandemic. The first recorded pandemic in history occurred in the spring of March 1918 and is known as the Spanish flu. This disease is caused by the influenza virus subtype AH1N1. It is considered as the deadliest outbreak because it affected 1/3 of the world's population and resulted to 50 million deaths. A few years later, another viral respiratory disease has caused a pandemic which led to approximately 1.1 million deaths. Influenza virus subtype AH2N2 is a causative agent of the Asian flu that transpired from 1957 to 1958. Yet another influenza virus has plagued the world in 1968. The Hong Kong flu, a pandemic caused by the influenza virus subtype AH3N2, has claimed approximately 1 million lives. In 1977, the Russian flu, a pseudo-pandemic, has caused alarm to the world due to the re-emergence of influenza virus subtype AH1N1. Moving on, we have here severe acute respiratory syndrome, or SARS. It is a viral respiratory endemic in 2002 and is caused by SARS-associated coronavirus. According to the WHO, or the World Health Organization, it was the first severe and readily transmissible new disease to emerge in the 21st century. Influenza virus subtype AH1N1 PDM09 is a causative agent of swine flu. This has caused panic across the globe in 2009. Another coronavirus-associated respiratory disease has emerged in 2012. It is known as the Middle East Respiratory Syndrome, which has affected 27 countries. Furthermore, on December 31, 2019, the World Health Organization China Country Office was informed of cases of pneumonia of unknown etiology. How did this pandemic begin? So from December 31, 2019, it started in Wuhan, Hubei province, China. According to the WHO, the viral disease was first reported in Wuhan City, Hubei province, China, and from December 31 to January 4, 2020, 44 cases were reported, and the etiologic agent was still unknown. On January 7, 2020, it was known to be a new type of coronavirus, according to the World Health Organization China Country Office. From January 11 to January 12, 2020, the virus kept on spreading in China. And on January 12, 2020, the virus was first named 2019 nCoV by the World Health Organization. On January 12, the first was named 2019 nCoV by the World Health Organization. On January 30, 2020, World Health Organization recommends that the interim name of the disease causing the current outbreak should be 2019 nCoV acute respiratory disease. Now the N stands for novel, while the CoV stands for coronavirus. Also, on the same day, January 30, 2020, World Health Organization, together with the Philippine Department of Health, reported the first case of COVID-19 in the country with a 38-year-old female Chinese national. On February 12, 2020, the disease was officially named COVID-19 by ICTV, or the International Committee on Taxonomy of Viruses. And on March 11, 2020, the World Health Organization has declared a state of pandemic. SARS-CoV-2, it is known as the seventh coronavirus to infect humans, and it is the causative agent of COVID-19. Now, for the ecological origin, according to the study of Zhu et al. Entitled "A Pneumonia Outbreak Associated with a New Coronavirus of Probable Bat Origin, SARS-CoV-2, isolated from humans, is phylogenetically and genomically identical to the SARS-like bat coronavirus. This bat viral genome is the bat coronavirus RATG13. According to the study, the bats, which are the primary hosts of the virus, can possibly be acquired by humans through consumption. Human-to-human transmission can occur by direct contact with respiratory droplets. The study also mentioned the possibility of an intermediate host. This intermediate host is known to be the pangolin. Therapeutic strategies are still being explored to combat the said disease. These strategies will be further elaborated by the next presenter. As for the transmission of the virus, the mode of transmission are three. We have contact and direct transmission. We also have fomite transmission. And lastly, airborne transmission. Now, for the mechanism of entry, how does the virus or how does human acquire the virus? For the mechanism of entry of your SARS-CoV-2, the virus can enter the human body through its receptors. Now, its receptors, if you can see in the presentation, the virus has spikes known as the spike glycoprotein. This spikes is responsible for attaching to a specific receptor in the target cell in the human host. And this specific receptor in the target cell is known as the ACE2 or angiotensin converting enzyme 2. Now, angiotensin-converting enzyme 2 is found in various organs such as the lungs, the heart, the kidneys, and the gastrointestinal tract, thus facilitating entry of the virus into the target cells. Now, the process of coronavirus entering into the host cell begins in the attachment, through the attachment of the S-glycoprotein into the receptor of the target cell. As mentioned earlier, it was angiotensin-converting enzyme 2. Aside from angiotensin-converting enzyme 2, another receptor is required for the viral entry, and that is now type 2 serine proteases. Now, this would now facilitate a conformational change in the virus, leading to its entry into the target host. After the virus has entered the host cell, it will now release its viral genome into the cytoplasm. The immediate release of the viral genome into the cytoplasm will now facilitate viral translation and replication in the host cell. After translation and replication of necessary proteins such as structural and non-structural proteins of the virus, this would now lead into the virus assembly. After a new virus or several viruses has been assembled, this would now lead to the viral release, meaning the virus that was formed into the host cell will now be released to infect other cells. As for the updates on the current situation of COVID-19 in the Philippines and globally, we have 14 million confirmed cases according to the WHO dashboard as of July 22, 2020. And for the list of countries with the highest confirmed cases, we have United States of America, we also have Brazil, Spain, India, and Russian Federation. As for the Philippines, as of July 22, 2020, according to the Department of Health, we have 72,000 confirmed cases. These are the list of references. Thank you very much for listening to my presentation.
Thank you for that very enlightening first lecture, Professor Sarmiento. As you can see, everyone, since the early days, the world already has its fair share of different pandemics, endemics, and epidemics, which more often include a variety of flu diseases. Now that we know how the virus is acquired, we now proceed to our next speaker. Our next speaker is a faculty of the Trinity University of Asia, College of Medical Technology, and at Manila Central University College of Medicine. Currently, she is a program coordinator of the Makati Health Department and is currently seeing suspected COVID patients on a daily basis.
Hello.
Without further ado, kindly welcome Dr. Irene V. Columbano.
Good evening to all participants. Thank you, VP Dr. Luna, Dean Rodriguez, Dean Bukoy, and members of the faculty for giving me this opportunity to share my knowledge and experience as medical frontliner. Tonight, I'm going to discuss the clinical manifestations of COVID-19 and updated interim guidelines on expanded testing for COVID-19. So what are the possible mode of transmission of COVID-19? Data suggests that respiratory droplets expelled during face-to-face exposure, like during talking, coughing, or sneezing, is the most common mode of transmission. Prolonged exposure to an infected person, being within 6 feet for at least 15 minutes, and brief exposures to individuals who are symptomatic are associated with higher risk for transmission. Brief exposure to asymptomatic contacts are less likely to result in transmission. Aerosol spread may occur, however, the role to human is still unclear. There were reports that SARS-CoV-2 was also detected in feces and urine, but there were no published reports of transmission of SARS-CoV-2 through feces or urine. An estimated 48 to 68% of transmission may occur via pre-symptomatic carriers. These are individual infected and may be shedding virus but has not yet developed symptoms. Moving on, Cheng et al. States that viral load in the upper respiratory tract appears to peak around the time of onset of symptoms, and viral sheddings begins approximately 2 to 3 days prior to the onset of symptoms. The mean incubation period is 5 days. This is the period between exposure to an infection and the appearance of the first symptoms. The median interval for symptoms onset to hospitals admission is 7 days. The median age of hospitalized patients is between 47 to 73, and 74 to 86% are age 50. Male predominantly admitted as compared to female. The three most common symptoms of COVID-19 are fever, dry cough, and fatigue. Moving on, so you need to consult a medical doctor if you experience the serious symptoms such as difficulty breathing, chest pain, and loss of speech or movement or bluish discoloration of lips. So the clinical presentation of exanthem and enanthem in patient with SARS-CoV-2. Picture A shows a coalescing purpuric macules distributed in buttocks in periflexular pattern. Picture B shows an enanthem on hard and soft palate consisting of PTK without erythema. Fever, dry cough, and shortness of breath are the most common symptoms seen in hospitalized patients. There are reports that approximately 3% of individuals with COVID-19 experience anosmia and ageusia as sole presenting symptoms. This is the decision tool used to triage patient with signs and symptoms of possible COVID infection or a symptomatic patient but with close contact with a confirmed COVID-19 patient. This table shows the comparison of old versus new COVID case definition for surveillance. All classifications are the following: neither person under monitor nor person under investigation, person under monitoring, person under investigation with mild, severe, and critical signs and symptoms, but who was not being tested and for testing. Person under investigation with mild, severe, and critical signs and symptoms, inconclusive, inadequate, or no available testing. And lastly, for COVID-19 positive. On the other hand, the new classification of case definition are the following: non-COVID case, asymptomatic, suspect case, probable case, and confirmed case. A suspect case was defined as a person with severe acute respiratory illness, having a fever of 38 degrees or higher, with cough or sore throat, shortness of breath, and may even include severe pneumonia, whose cause is undetermined prior to testing for the coronavirus, or a person with influenza-like illness, fever of 38 degrees or higher, cough, sore throat, and who lives in or has traveled to an area that reported local transmission of the coronavirus during the 14 days prior to the onset of symptoms, or a person with influenza-like illness and has contact with a confirmed or probable case of COVID-19 2 days prior to the onset of illness of that confirmed case or before that confirmed case showed a negative result on repeating testing, or a person with fever or cough or shortness of breath or other respiratory symptoms and is one of the following: age 60 years old and above with comorbidity and pre-existing illnesses such as hypertension, diabetes, chronic renal disease, in high-risk pregnancy, or a health worker. A probable case of COVID-19 is defined as a suspect case who has been tested for COVID-19, but the results are inconclusive. A suspect case who has tested positive for COVID-19, but the test was not conducted in a national or subnational coronavirus reference laboratory. And a confirmed case is defined as as a person may be considered only if they were tested at a national or subnational reference laboratory or at a DOH certified laboratory testing facility. COVID-19 case. Moving on, this slide shows that doing intervention such as social distancing, wearing of PPE like face mask and face shield, and going to an open air places and isolating COVID-19 patient reduces the probability of acquiring COVID-19 disease. So this is the algorithm on the use of rapid antibody tests for testing COVID-19 among asymptomatic patients and healthcare workers with relevant history of travel or exposure. This slide shows that testing of all symptomatic patients who are close contact of a confirmed or probable case must be conducted by healthcare workers equipped with proper personal protective equipment. Patient must be isolated at all times. So the DOH updated interim guidelines on expanded testing of COVID-19 dated May 29, 2020. So COVID-19 immunity. According to WHO or World Health Organization, there were no study evaluated whether the presence of antibodies to SARS-CoV-2 confers immunity to subsequent infection. False negative result of RT-PCR may be due to inadequate sample and inappropriate timing of collection in relation to symptom onset. The probability of a false negative result in an infected person decreased from 100% on day 1 and 68% on the day 4 on the onset of symptoms. The median false negative rate was 38. The false negative rate was minimized 8 days after exposure, 3 days after the onset of symptoms on average. So what are the current evidence-based treatment? Supportive treatment, including the supplemental oxygen, is the main treatment for most admitted in the hospitals. Recent trials indicate that dexamethasone, a steroid drug, decreased the mortality of patients who are hooked to mechanical ventilator or to those patients who required oxygen supplementations during admission in intensive care unit. Antivirals such as remdesivir only improves time of recovery of patients. Treatment regimens are listed below. These are available for the treatment of critically ill COVID-19 patients. However, there is no sufficient evidence to support the routine use of the said regimen for critically ill COVID-19 patients, except in the context of clinical trial or compassionate use. Chloroquine or hydrochloroquine is not recommended for pre- and post-exposure for COVID-19 infection. So last July 21, 2020, WHO released a draft landscape of COVID-19 candidates vaccine. There are 24 vaccine candidates in clinical evaluation and 142 vaccine candidates in preclinical evaluation. As of today, there is still no approved vaccine against COVID-19. And to summarize, most mode of transmission of COVID-19 is still through respiratory droplets. We discussed the clinical presentation of COVID-19. 3% of the patient with COVID-19 sole presenting symptoms is loss of smell or taste. Social distancing with the use of face masks and face shield is an effective intervention in preventing COVID-19 disease. Rapid antibody test is an adjunct and shall not be used as standalone test to definitely diagnose or rule out COVID-19. Supportive care, including supplemental oxygen, is the main treatment for patients with COVID-19. There is no approved pre- and post-exposure chemoprophylaxis against COVID-19. There is insufficient evidence to support the routine use of antiviral, steroids, and others for critically ill patients, except in the context of a clinical trial or compassionate use.
Thank you for that lecture, Dr. Columbano.
Thank
Now that
you.
we know how the virus is acquired and its manifestations, we can now proceed to our next topic. Our next speaker, last but not the least, is a full-time faculty member of the Trinity University of Asia, College of Medical Technology. Most recently, he served as a volunteer at the Manila Health Tech Incorporated under the leadership of Dr. Raul V. Destura. Now, he is with San Miguel Foundation Testing Laboratory, still serving as a volunteer. Let us all welcome Mr. Angelo Christian O. de Guzman. Hello, Mr. Angelo. How are you?
Hi, Doctora. Good afternoon po.
Good afternoon. Are you from duty?
Today, earlier po. Yes.
So, can you share to us a little bit of your experience in volunteering to these different institutions? How was it? Are you testing number of samples a day? How many per day? Can you please enlighten our participants?
So currently, Attorney Dr. Pulido, we are testing more than 1,000 specimens a day. So there in the laboratory, more than 1,000 swabs in the laboratory per day. We have to test it and it's released within 24 hours.
Oh, okay. So you are pertaining to the San Miguel Foundation Testing Laboratory, isn't it, Mr. Angelo?
Yes, Attorney Doctor.
So you mean you are testing 1,000 patients a day? Who get the samples?
There are trained healthcare professionals who get the swab samples from the patients, and they they are also the ones who transport the specimens to the laboratory, and then we are the ones who test.
Okay. Sir, for example, I want to be tested. How do I go to your institution? Do I just walk in, or can you please tell us the procedure?
So currently, doctor, I can't divulge
Okay.
any information regarding that because it is still undergoing um, talks with the upper management.
Oh, okay. So just to clarify, the tests you are doing are swab tests, isn't it?
Yes, doctor. Yes,
Okay.
we are doing the molecular testing, the reverse transcriptase real-time polymerase chain reaction.
Oh, okay. So I will not make chica anymore. I will not hold you any further. We are now going to present your lecture.
Thank you, Attorney Doctor. So, good evening to everyone. So, before I start my presentation, I would like to take the opportunity to thank the College of Medical Technology and the Graduate School MSMT program for trusting me to share about the analytical methods used for the detection of SARS-CoV. Very excited to share to everyone what I am currently experiencing in the field of molecular biology and immunology. So before I start, all product and company names and trademarks of their respective holders. It doesn't imply any affiliation with or endorsements. So now may I ask you all a question. For the detection of SARS-CoV, what do you think is preferred? Antigen or antibody detection? So it's serological or nucleic acid testing. We must understand how, when, and why it is. The first question is how. How do we use the test kit for antigen and antibody detection? We all know that the antigen is the virus. According to the fundamentals of immunology, some antigens are immunogens, which can elicit an immune response, thereby producing antibodies. So we can see this graph, when and why it is used. So the left y-axis is viral RNA count, the right y-axis, the antibody titer, and the x-axis represents the days after infection. So the specimens collected from the upper respiratory tract, like the nasopharyngeal swab, is common in practice, while sputum for the lower respiratory tract. The peak of viral shedding appears in 3 to 5 days after infection. This is the preferred time to collect the specimen. The coronavirus is an RNA virus. Therefore, it is important to convert RNA from the virus into its complementary DNA sequence using reverse transcriptase. The detection of the unique sequence of RNA fragments of coronavirus is diagnostic, and this test can be used to diagnose COVID-19 in its early stages when the patients are highly infective. So may I ask you again this question, and I will leave you this question because it will be discussed later. What do you think has the highest viral yield of SARS-CoV-2, the nasopharyngeal swab or the sputum? So when COVID enters our body, it stimulates our immune system to fight the invader. One way is to create the antibodies that can destroy the virus. The first antibody formed is IgM, typically introduced 8 to 10 days after the initial onset of infection. Also with this is the IgA, which is the antibody or the immunoglobulin found on your nasal and mucosal surfaces, such as your nose, your pharynx, and your lungs. It both of the immunoglobulin M and immunoglobulin A peaks after 1 month and slowly decline because another antibody is formed called your immunoglobulin G, rising 10 to 12 days after the infection and remains in the blood for a long time. The patient will slowly recover as the virus is fought by the immunoglobulin. Then by the third week of infection, in most cases, the number of active viruses disappear. I will leave you another question. There are 3 antibodies formed as a response to SARS-CoV-2. What are these antibody serological testing that can be used, that can be detected using the blood? You can comment your answer in the chat box here in the FB Live of whether it is the IgG, the IgM, the IgA, or the 3 of them detected. Or maybe just 2 of them can be detected. You can answer, you can post your answers or your comments in the chat box in the FB Live. To answer the question, let's look at the acceptable treatments. For serological testing, we have this technique in the full blood. And for nucleic acid testing, you see there's an arrow. That arrow in the nucleic acid test depicts the specimens with the highest yield of viral load to the lowest viral yielding specimen. Based on studies, Based on studies, the highest yield of specimen is the bronchoalveolar lavage, followed by your sputum, the nasopharyngeal swab, bronchial brushing or bronchial washing, then your oropharyngeal swab, the feet, and then the saliva. Blood or serum for antibody or serological testing, depending on the specimen stated for every kit, provided that the specimens must be collected by a trained healthcare provider. May I ask you another question? Is urine currently accepted as a way of diagnosing or screening COVID-19 infection? You can leave your answers again in the chat box in the FB Live. But now we will answer, is it acceptable or is it not acceptable? Although very low in viremia, SARS-CoV-2 has been isolated a few times from the urine specimens. According to an article published in the Journal of Medical Virology on April 24, 2020 by Peng et al., SARS-CoV-2 can be detected not only in the blood, not only in the oropharyngeal swab, but also in the urine and the anal swabs. According to an article, so again, I will repeat that according to an article published in the Journal of Medical Virology on April 24 by Peng et al., SARS-CoV-2 can be detected not only in the blood and in the oropharyngeal swab, but also in the urine and anal swabs. So I am putting my hat now as an RMP, talking about all the specimens, talking about how we collect the specimen. The most important step currently is hand washing. Now, almost all specimens have some levels of green, so it is important for everyone to observe proper hygiene. Where are specimens placed and how is it transported? So the swabs should be placed immediately into a sterile transport medium containing 2 to 3 ml of either viral transport medium or universal transport medium, Amy's transport medium, or sterile saline. What is good with the viral transport medium? They prevent the growth of fungi and bacteria, which isolates and maintains the integrity of the virus we want to test. How? The PTMs are inhibitory because they contain an antibacterial, which is your gentamicin, and an antifungal, which is your amphotericin B. Because majority of exogenous RNases in the environment are produced by fungi and bacteria, we have to inhibit the growth of these microorganisms to prevent the degradation of the we want to detect. And as you can see, there are swabs only acceptable, such as your synthetic fiber swabs, the tapered swabs, and your polyester swab. We should not use calcium alginate swabs or swabs with wooden tips because alginate is an extract from seaweed and it's responsible for inhibition during PCR testing. So out of concern for the inhibition of PCR and activation of the virus, we have to refrain from using these swabs. So we also have the AMIs and sterile saline. We now go to how are we going to reject specimens. We have incorrect labeling. In the Philippines, we have the no case investigation form. According to CDC, the NPS or the nasopharyngeal swab is the recommended sample. Some institutions do not accept oropharyngeal swab. But if no other types of specimen or swabs are available, the oropharyngeal swab can be used. There is also the leaking specimen, the improper temperature storage, if not kept at 2 to 4 degrees Celsius within 4 days, or not kept at negative 70 degrees Celsius if it is longer than 70 days. Well, of course, we need to reject if the transport media has no specimen. We cannot test if we do not have. So we need to inform the swabbing site that maybe because of the voluminous samples taken, forgot to place a sample in the transport media. Let us now go to the serological testing. So most COVID-19 rapid test kits are based on qualitative lateral flow immunochromatographic assay for the detection of IgM and IgG antibodies to SARS-CoV-2 in human whole blood or serum samples. So the cassette will contain antigen from SARS-CoV-2 conjugated to nanoparticles, which are detected by the antibodies present in the sample. So if there is IgM, they will attach to the uh, antigens that are connected to the nanoparticles, and they will form a colored line because of the particles. And you have to remember that a control region on the upper end should be present so that you can say that it is a successful testing. So how are we going to interpret? If there is no control band, it is an invalid test run. You should retest the sample, and there should always be a control band. If there is a control band, but IG control bands are not present, it means that the patient is likely negative for antibodies against SARS-CoV-2. If IgM is present, the band for IgM is present, there's an ongoing or current infection. IgM positive and IgG positive with the control band means that the patient is already undergoing recovery, but still with infection. If IgG is positive and there is no band for IgM, it means that the patient has recovered and has developed antibodies. For nucleic acid test, we will detect the genetic material of SARS-CoV-2. But first, we have to extract that nucleic acid first. We can generally categorize nucleic acid extraction procedure in 5 steps. We have inactivation, lysis, purification, washing, drying, and elution. The inactivation will render the virus non-infectious, and we can achieve this by using or chemicals. Based on my experience, I personally use the heat inactivation. It can be done using 56 degrees Celsius for 30 minutes or 65 degrees Celsius for 10 minutes. Lysis is achieved by using chaotropic salts that will facilitate the lysis. Drying is an important step because ethanol can affect PCR testing. The silica must be free from ethanol before we elute. And elution is the step to suspend the attached genetic material to the silica filter. And once centrifugation is done, it will settle at the bottom of the tube, which can then be used for testing. Templating is the last step before we proceed to PCR testing. And it is where we place the samples and the PCR mix, master mix, in the PCR strips for testing. So there are components. We have the template, we have the primers, we have the DNTP, we have the Taq polymerase, we have the cofactor, the buffers, and the PCR water. Based on these components, what do you think is the component that gives the PCR testing, the nucleic acid testing, its specificity? Again, what do you think is the component in this line, in this presentation of the PCR mix that gives the nucleic acid testing its specificity? You can comment your answers again in the chat box in the FB Live. So the answer is, of course, your primers. You use two primers, the forward and the reverse primers. These primers are specific sequences that is custom synthesized and are very critical for a successful PCR reaction. The two primers must match the two ends of the segment we want to amplify. Okay? So let us have an overview of the basic steps of PCR. We have denaturation. It is the step where the DNA, double-stranded DNA, is separated into single strands. We have the annealing, where primers bind at the complementary sequences of the denatured strands, and extension, where nucleotides bind to the annealed primer, resulting in an exponential amplification of the temperature. So there are genes that we detect for PCR testing. In the Philippines, for SARS-CoV-2 and pan-coronavirus, the general coronaviruses, we can detect 5 genes: the E gene, the RDRP gene, the ORF1AB gene, and the S gene. Here, it depends on the kit that will be, it will depend on the primers, so we can detect what type of gene we want to amplify. For the internal control, mostly it is the RNase P gene, but we can also use the ABL1 gene. So how do we perform quality control? For the negative control or the template control, there should be no amplification in it. I encircled here the CP value, which is the value where the curve has reached the threshold value. This is very important because there should be no value in the CP and there should be no amplification in the graph. For your positive control, it should have an amplification for all the genes. If there is amplification, what does it signify? It means that the run is valid and that the machine is in control and can detect amplification. For internal control, it is already for the samples. So there should be an amplification of the internal control gene, which means that there is a successful extraction of the genetic material from the sample. The run for the sample is invalid. There is no amplification of the internal control. So there are a lot of interferences for nucleic acid testing, but I would like to focus on one interference, which is the ribonuclease. So these are nucleases that degrade RNA. We have two types of RNases. We have the endogenous RNases, which are from human samples, human tissues and cells, and your exogenous RNases, which are from the environment. As I said earlier, in the environment, bacteria and fungi contribute mostly to the RNases present in the environment. There will always be innate RNases in our samples. That is why we have to correctly store it to avoid RNA degradation in 2 to 4 degrees Celsius if it's less than 4 days, or negative 70 degrees Celsius if it is more than 4 days. Also, that the RNA aliquot on the it should be placed in ice and it should be covered when we are performing on bench proofs. And we have to remember that the cold racks should be used when we are using when we are doing templating so that we can avoid or slow down the action of RNases. So for the reliability of testing, we are considering the clinical sensitivity and the clinical specificity. For serological testing, because it is a screening test, there should be a sensitivity, high sensitivity, because they are the screening test. It means that they detect true positives. Nucleic acid testing is the confirmatory test. That is why it should have high specificity. It means that they can detect true negatives. As you can see here, the nucleic acid testing has very high clinical specificity, while the serological testing as a screening test has high clinical sensitivity. What is the biggest source of PCR contamination? It is the aerosolization of PCR products. It is created when you open a tube or pipette amplified PCR products. Being very small, they can travel very quick. They can easily spread all over your bench tops, your equipment, or they can find their way into your next PCR testing and can be amplified. This will cause false amplification or false results in your sample. So let us summarize. We have again two general testing for our SARS-CoV-2. We have your serological testing and we have your nucleic acid testing. So serological testing is a screening test based on CDC interim guidelines. What are the methods? We have the rapid test kits, we have the ELISA, the ECLIA, and the CLIA. When is the best time to use the serological testing? Again, it is during the late active, which is the 2 to 3 week span, and post-infection after 1 month. The specimen that is used is your skin punctured blood or blood. Results may take 1 to 2 hours turnaround time. The turnaround time here is from the specimen collection until the release of results, because the analytical procedure itself is only 15 to 20 minutes. But we have to remember that there are analytical and post-analytical variables. Standing of whole blood for clotting takes about 30 minutes. So we have to consider pre-analytical variables as well, when we are determining turnaround time. Interpretation of serological testing, again, if it is negative for IgM and IgG, it is likely negative for SARS-CoV-2. IgM is positive and IgG is negative. Current infection during the 2 to 3 week span of infection. IgM is positive and IgG is positive. We are already ongoing the period of recovery, which is from 2 to 3 weeks after the onset of illness. If IgM is negative and IgG is positive, there is past infection already. It is more than 1 month after the onset of illness. Do we need confirmatory for serological testing? Well, based on DOH Circular 2020-0174, if the IgM is positive, the patient is a probable COVID-19 case. So we have to collect swab samples for RT-PCR testing. What are the limitations of your serological testing? Number one, it cannot diagnose active coronavirus infection, and it cannot show you that you do not have COVID-19. For the nucleic acid testing, it is the confirmatory test, again based on interim guidelines and also based on DOH 2020-0174. The method is the reverse transcriptase real-time polymerase reaction. The best time to use this is during the incubation period, with a mean of 5 days after the onset of illness to late active infection, from 2 to 3 weeks after the onset of. The specimen used is your nasopharyngeal swab, the oropharyngeal swab, the sputum, or the saliva. Results may take up to 1 day, but if it is just a single specimen, from receiving the sample receiving to releasing of results, it would take you approximately 3 hours. For the interpretation of result, it is either the SARS-CoV-2 viral RNA is detected, SARS-CoV-2 viral RNA is not detected, or it's invalid due to specimen quality. Do we need to confirm the nucleic acid testing? Well, it is typically highly accurate, so we do not need it to be reconfirmed. What are the limitations of your nucleic acid testing? Well, it cannot show if you ever had COVID-19, and it cannot show if you were infected with COVID-19 in the past. So if you are going to combine your serological testing and nucleic acid testing, how are we going to interpret it? How are we going to harmonize the serological and the nucleic acid test results? If the serological test is positive and the nucleic acid test is also positive, it is most likely that you do have an active COVID-19 infection. If the serological test is negative and the nucleic acid testing is positive, it is most likely also that you currently have an active COVID-19 infection. If the serological is positive, but the nucleic acid is negative, you likely have had and recovered from COVID-19 infection. And for serological negative, and the nucleic acid is also negative, it means that you likely have never had COVID infection. So this is how we harmonize if we have serological test results and nucleic acid test results. So with this, I leave you with always wash your hands, always wear a face mask when going outside, observe spatial distancing, and let us always boost our immune system by eating. Thank you, and let us tweet, let us put in our Facebook messages the hashtag Stop COVID Spread. Thank you.
Wow, those are very informative presentations. Thank you, dear speakers. I hope after these three lectures, COVID-19 disease is a lot clearer to everyone. We will now proceed with the panel discussion. Again, as I mentioned earlier, should you have any questions, kindly post them in the comment section below, carefully observing the virtual etiquette guidelines. Now, before we start answering the previously submitted questions, let me introduce you with tonight's panel discussants. We're supposed to be joined by Professor Joy Calayo, but she cannot due to an emergency. Thus, let me introduce you to our sole panel discussant, Professor Geraldine Dayrit. Professor Dayrit is from the University of the Philippines, Manila College of Public Health, and Trinity University of Asia Graduate School. She is at the moment a volunteer medical technologist of SARS-CoV-2 molecular testing under the Bayanihan to Heal as One Act. Let me introduce you, Professor Dayrit.
Okay, thank you, Dr. Attorney Polido, for that warm introduction. Can you hear me clearly, Attorney?
Yes, ma'am.
Okay, thank you very much for that response. Good evening, DP Luna, Dean Bukoy, and Dean Rodriguez. Also, good evening po to those in the Philippines. Good afternoon to those listening from different parts of Asia. And good morning to all Trinitians by heart and mind from the western part of the globe. May I request for a thumbs up reaction if you are feeling fulfilled and intellectually satisfied today. Okay, I can see handful responses. Thank you very much for this generous response. I am a positive person. I always look at the brighter side of life rather than crying over spilt milk. The Generation Y and Generation Z would now ask, WDYM by crying over spilt milk. LOL, DNYW. You, Generation Z, have words that we need to decipher as well. This pandemic has been a catalyst of a very big change. Actually, long overdue of transmission, I should say. The generation has evolved from my Generation X and Y way of traditional teaching to Generation Z's transition to remote and digital delivery of knowledge. If I will be asked, SARS-CoV-2 to NAT or not, of course, being positive person that I will go for NAT with a capital A. As medical technologists, this method would give a lot of opportunities rather than being negative. However, for every rule, there is always an exemption. That is, receiving a true negative result from NAT. So, I will go for the not result with an O for a NAT. Thank you very much, attorney, and I hope I am ready to answer all the queries of our audience and participants, especially our students.
Okay. Thank you, Professor Dairit. But before I throw you the questions, let me first clear it, ha? Kasi you mentioned earlier that you're a positive person. So as to not confuse our netizens, can you explain, elaborate to us, is that figuratively or or literally positive?
Okay, that brought a double meaning pala for me. Okay, for you actually, attorney Dr. Polido. So it is figuratively speaking that I am a positive person. Okay, I am not positive to SARS-CoV-2 RT-PCR result. Just to make clear. Okay? Okay, just to be clear on that.
Okay,
So,
thank you for that clarification,
yes.
Professor Dairit. Okay, we will now start with the questions. The first question is, if a patient was quarantined for 14 days, what test should be done to be considered safe and ready to join the population? Is it rapid antibody test or RT-PCR?
So for that question, I would like to think that the patient mentioned was a COVID-19 patient. Am I right, attorney doctor?
Yes, ma'am.
Then, yes, was quarantined for 14 days. As mentioned by Dr. Columbano in her lecture, can we show Dr. Columbano's lecture on quarantine isolation for 14 days, guaranteeing 100% reduction or non-transmission of the virus as an effective intervention for prevention. And if I may add, an effective COVID-19 management. So to answer if the recovered COVID-19 patient is considered safe and ready to join the community or the population, I would like to refer on a scientific brief released by the World Health Organizations on criteria for releasing COVID-19 patients. The initial recommendation, to confirm the clearance or to confirm the clearance of the virus and thus allow discharge from isolation required a patient to be clinically recovered and have to have 2 negative RT-PCR results on sequential samples taken at least 24 hours apart. This recommendation was based on the knowledge and experience with similar coronaviruses, as mentioned by Professor Bulago. Okay? That the SARS and MERS outbreak in the 2002 and 2012 respectively. As mentioned, can we show the the slide of Professor Bulago on the timeline of notable viral respiratory outbreaks. If it's still possible for us to show, so that they would know that most of the guidelines developed by World Health Organizations were initially based from the experience and knowledge, okay, during the outbreak, experienced in the outbreak in 2002 and 2012. Yes. However, thank you for showing the slide for a recall, especially to our students. However, they have released new recommendation as part of the clinical care pathway of a COVID-19 patient. These criteria apply to all COVID-19 cases, regardless of isolation location or disease severity, without the need for retesting twice, but with extended quarantine and isolation. However, countries may choose to continue to use testing as part of the release criteria. Different countries are pursuing different strategies when it comes to testing for COVID-19. But policies around the world vary, and there seems to be arguments in support of different approaches. Largely, it is because of the supplies, shortages, and priorities. Testing for me is important because asking people with mild symptoms just to stay home will lead to more infections rather in the household and community. If tested and positive, people can either be isolated in a facility or put on strict home isolation. When resources are limited and when the healthcare system is overloaded like what is happening right now, we don't want a lot of people to get sick and coming to health facilities and risking contagion. Policy is important on testing different testing differs from one region to another, from one country to another, or even city to city. It depends on what strategy the community has reached in the pandemic curve and level of preparedness in the specific context. In our country, we still follow the retesting release criteria of the World Health Organizations. As mentioned in the previous talk, infection with virus SARS-CoV-2 causing the COVID-19 disease is confirmed by the presence of viral RNA detected by NAT. To be specific, using RT-PCR. Factors that determine transmission risk include whether a virus is still replication competent, whether the patient has symptoms such as cough, as mentioned by Dr. Columbano, which can spread infectious droplets, and behavior and environmental factors associated with infected individual. Usually, 5 to 10 days after infection with the virus, SARS-CoV-2, the infected individual starts to gradually produce neutralizing antibodies. Can we show the slide of Sir Angelo de Guzman? Wherein binding of these neutralizing antibodies to the virus is expected to reduce the risk of virus transmission. Can we show the, okay. To be considered safe is collecting the right sample and utilizing the right method. Combination of tests is better. RT-PCR detects the presence of the virus. Take note of that. While the rapid antibody test or even other antibody test procedures, not the rapid test kit that we know of as of now, determine the immunologic response of the body. Ergo, laboratory results should be interpreted together with the available clinical and epidemiological information. So, I hope I was able to answer that question, Attorney Doc Polido.
Yes, Ma'am Gigi, that was an elaborate explanation and we love it very much.
Thank you.
I want to summarize, okay? So say example, this is for the benefit of our non-medical participants, okay? I know we may have participants who are not in the field of medtech or who are not doctors. So they want to know if, for example, I quarantined after 14 days, okay? What test should I do from the beginning? I was symptomatic, okay? I was tested for RT-PCR, okay? I tested positive. I was treated, mild symptoms. I was okay after 7 days. Then I was sent home, asked to quarantine again for another 14 days. What do you suggest to do? Which testing?
Okay. I think I can we ask
Yes,
Dr. Columbano? Okay, being the medical specialist as the expert on this.
okay. Dr. Columbano, are you there?
Yes, ma'am. Sorry. What's the question
Hi.
again, ma'am?
Hi, Doc.
Hi. Yes, po, ma'am.
Good evening. Okay, my question was, I know you've been seeing a lot of COVID patients, suspected COVID, probable COVID patients on a daily basis. So my question is, if I'm the patient, this is again for the benefit of our non-medical participants, okay? So I tested positive. I was symptomatic, mildly. I was treated for 5 to 7 days. I went home, I was okay. My boss asked me, oh, when are you going to go back to work? And then you told the patient quarantine for 14 days. Okay, so he did quarantine. After 14 days, he goes back to you, Doc, what test do I do so that I will be safe to join the population?
Okay. As a medical practitioner, we do RT-PCR testing to confirm if you have COVID disease. After 14 days, if you are symptomatic, we will do the rapid testing. If you develop IgG on that test. If you develop IgG, that means that you already recovered from the disease.
So
if you don't have it,
yes, okay. Sorry, Doc.
yes, yes. Yeah, it's okay. So if you don't develop IgG, still positive for IgM, that means that you're still infectious. So you're not allowed to go back to work for that case. Still, we will do another 7 days quarantine. And after 7 days, rapid testing will be repeated.
If the rapid test revealed IgG
after 7 days, if you already develop IgG, that means again you are already recovered and you are safe to go back to work.
Thank you for that.
Provided that you are already asymptomatic, you don't have any symptoms at all.
Okay, I hope that was clear to all our participants. So to the person who submitted the first question, thank you. Very beautiful question. We now go back to our panel discussant, Professor David.
Yes, Attorney Doc.
Okay, so for our second question, considering the scenario that uses samples from a COVID-19 suspect, what is the reason behind repeated positive results of SARS-CoV-2 IgM using different types of test kits available in our country, yet tests negative for PCR?
Okay, the question is technical, but before I would go directly answering, and for the sake of discussion, we have to consider 3 points in here so that we could accurately and precisely answer the question at hand. So, Attorney Doc, I would just like to confirm, we are talking about COVID-19 suspect patient who is symptomatic, right?
Yes, yes.
Okay. SARS-CoV-2 IgM positive and PCR negative.
Yes.
So for the IgM tested positive twice.
Positive.
Twice. Okay. So we have to take note that the timeline or the time interval of the collection and days after onset of symptoms is not mentioned in the problem. Am I right, Attorney Doc?
Yes, ma'am.
Okay po. So, let's take into consideration first, COVID-19 suspect case. So, based on the DOH definition, this is a person who is presenting all SARI cases. When we speak of SARI cases, these are severe acute respiratory infection cases. A person also having influenza-like illness cases or ILI cases. And individuals with symptoms fulfilling any of the following, like mentioned by Dr. Colombano. So this part, knowing the patient is symptomatic or asymptomatic, in this case, the doctor will take charge of it. Right, Attorney Doc?
Yes,
Okay.
ma'am.
So on the second part, note SARS-CoV-2 IgM positive. I would like to refer to the DOH or Department of Health Department Memorandum 2020-0180, the revised interim guidelines on expanded testing for COVID-19. The guideline reiterated the use of the real-time PCR reaction testing as the confirmatory test. In the Philippines, this pertains to RT-PCR test kits that are approved, take note, approved by Food and Drug Administration and validated by the Research Institute of Tropical Medicine or RITM. While the rapid antibody test kits shall not be used as standalone, as mentioned on this memorandum, to definitely diagnose or rule out COVID-19 because this must be in conjunction with the RT-PCR. Take note that RTK or rapid test kit is not available over the counter not like the pregnancy test. Right, Attorney Doc?
Yes, ma'am.
Okay. Yes. PPE and other materials used in testing shall adhere to existing guidelines on the management of healthcare wastes. Proper disposal of contaminated samples and waste materials would pose risk from these bloodborne infections. So hereby, as mentioned by Dr. Colombano about the symptomatic non-healthcare workers guidelines on this DM or Department Memorandum 2020-001-0180. Okay. If IgM positive, the patient is a probable IgM. So, using the rapid test kit, the patient is a probable COVID-19 case. So, collect swab for RT-PCR testing. Can we show the algorithm this as in the lecture of Dr. Colombano on the testing of symptomatic patient? I believe if it's available, we can show to our audience and listeners. Okay. So the next one, the algorithm. The algorithm. Okay. The algorithm, if you can see clearly, the Department of Health has set guidelines on this. So if tested positive for IgM, and then you proceed to RT-PCR. So the case at hand is RT-PCR negative. So the patient has to complete a 14-day quarantine or until asymptomatic, whichever is longer, and repeat rapid antibody-based test once asymptomatic. So, why this happens? If we try to recall Professor or Mr. Sir de Guzman presentation on the biomolecular profile of SARS-CoV-2 infection. So it would be better if we could show them the slide back, if available. Okay, when the virus enters our body, it stimulates the immune system to fight against the infection. One way of the defense system is to produce antibodies. On this part, can you see the part wherein there is the increasing amount of our antibodies at the right side? Okay, so when the body, I would repeat, so when the virus enters our body, it would stimulate the immune system to fight this infection. One way of the defense system is to produce, as we have mentioned, antibodies that can destroy the virus. Usually, patients start producing IgM type of antibody within 8 to 10 days of infection, as we can see on the slide. It will reach a peak in about a month of the infection and then slowly declines. The patient also produces another type of antibody. So in the case, we only have IgM. So we can see the IgM going down as the time progresses. So at the level of these antibodies wherein the IgG would also start to rise, okay, the virus could be neutralized and the patient slowly could recover from the disease. Therefore, in most cases, number of active viruses disappear by the third week of the infection. The third point, why PCR is negative? Okay, we all know that the gold standard for testing is PCR. PCR is a laboratory tool to identify a specific segment of DNA in the sample. Take note, I mentioned DNA. In this technique, a target DNA in the sample is amplified millions of copies, allowing for easy detection. But the coronavirus is RNA, ribonucleic acid virus. It does not contain DNA. Therefore, it is necessary and it is a must for us to convert this RNA from the virus into its complementary DNA or the cDNA. Therefore, okay, this DNA, this test of converting the RNA to cDNA is called the reverse transcription with the presence of reverse transcriptase. That's the term RT-PCR, reverse transcription PCR or polymerase chain reaction. As this virus can multiply its number in the cells of the respiratory parts. Okay, it could be, that's why the specimen samples could be taken out from upper respiratory tract, okay, like the nasopharyngeal swab as mentioned by Mr. De Guzman, and also the bronchoalveolar lavage from the lower respiratory tract, which can yield more viral recovery. The peak of viral shedding appears 3 to 5 days after infection. So, the preferred time for the collection of specimen is very crucial. Okay? It is important to note that positive PCR, that means the sample contains RNA, contains the RNA of the virus. It does not indicate that the virus is alive in the sample. To confirm if the virus in the sample is viable or alive, virus should be cultured, and that is not available here in the Philippines. Yet, in RT-PCR test, we have what we call the limit of detection. That is why sometimes maybe we would be confused why RT-PCR is negative. We have what we call the limit of detection. The assay may not be effective as a diagnostic tool for specimen below the limit of detection. We have to take note that non-detection or absence of the target nucleic acid using RT-PCR does not rule out infection. So what are the factors contributing to non-detection of target nucleic acid fragment? It could be the timing of specimen collected. Appropriateness of the specimen material, specimen collection technique, and the nucleic acid isolation technique. So I hope I was able to answer accurately and as precisely as possible that question. Thank you.
Yes, I agree with you, ma'am. This question is very technical. But if you may, the doctor in me speaking, I will summarize it clinically, no? So, the question was considering the scenario that the patient is IgM positive but tests negative for PCR. So, in short, most probably the patient who acquired the virus previously, that's why he seroconverted or developed IgM, was most probably because the virus is not present anymore. Or
yes,
present but not detectable, as you mentioned earlier. So, in short, in Tagalog, pagaling na siya. Right? But the next question is he infectious? Is he not? As answered by Dr. Columbano earlier, still may be infectious, so not safe to return to the community, and will still do further testing and quarantine. So, to the person who submitted the second question, I hope this is clarified. We can now proceed to the third question, Professor David.
Yes, ma'am.
Okay. For the third question,
okay.
Can a symptomatic person pass COVID to others and experience critical illness?
Yes, they are highly infective. They should be isolated for at least, as we have mentioned, at least 14 days. Okay. Yeah.
On the other hand, how can an asymptomatic person infect another?
Okay. Yeah, I think this would be better and can be answered directly by by Dr. Columbano, because she mentioned this already on the slide. Viral load in the upper respiratory tract appears to peak around time of symptom onset. And viral shedding begins approximately, as she had mentioned, 2 to 3 days prior to the onset of the symptom. I would like to give the definition that viral shedding occurs when a virus replicates inside the body and is released into the environment, meaning infectious na po, transmissible already. So, I would like to highlight this one in the study conducted by Dr. Zhu and team and was later published in the New England Journal of Medicine in March 2020. The viral load that was detected in the asymptomatic patient, take note, was similar to that in the symptomatic patients, which suggests the transmission potential of asymptomatic or minimally symptomatic patient. These findings are in concordance with reports that transmission may occur early in the course of infection, or what they call the pre-symptomatic stage, and suggest that case detection and isolation may require strategies in the earliest detection time. So I hope,
Professor David, we both agree that despite being asymptomatic, you can just sit on the couch and tell everybody, oh, I don't have COVID, no? So there is still a possibility that you might be infectious, you might infect someone who is immunocompromised, and other than you, who is actually minimally symptomatic or asymptomatic, that other person that is typically ill later on. Okay, we now move on to the fourth question. Okay, how do healthcare workers like you handle the discrimination, if any, from people that surround you? What can you impart to those future forces of the healthcare system in this country?
Okay. To tell you the truth, I have not encountered any discrimination from people surrounding me. It is actually me who is discriminating myself. I don't know, attorney. Am I self-incriminating? Okay, because I do
You're not
this.
in court, Ma'am David. Okay lang yan.
Okay, I do this because I would like to protect people, especially my loved ones, by being extra careful before going back to home from work. You know, because that I know I am directly or face to face battle with the virus. So I make it a point I am clear whenever I go back to my loved ones. So so far I haven't actually I am given more privilege now because we have a special lane for that. So
I agree with you.
yeah, when we do groceries, so it's an opportunity. It's a quite good feeling for me for not being discriminated. But I discriminate. I don't know if I'm right. I self-incriminate. Okay.
With that experience, Ma'am G, what can you advise to our future medical practitioners who are listening right now?
Okay. First, you're working because this is what we have. This is our profession. We're doing this because this is what we have promised to work for. Okay, so we do our work with passion and following the guidelines, and they are calling us the new heroes, right? Bagong bayani raw ng bayan. Pero I don't see myself the big bagong bayani, the new hero, because this is what I'm doing from the very beginning. So then why do they have to call that way? So the bagong bayani or the new heroes are those who are not or who are adhering to the policies,
Yes,
who
I
are
agree with you.
obeying the rules of our government, right? So if we are told or asked to stay at home, we have to stay at home. If we have no business going around, going outside, stay at home, wear our mask properly whenever we go outside, and practice social or physical distancing.
Yes, I agree with you, Professor David, that the term bagong bayani is not limited to those in the medical profession and those other
Correct.
workforce like security guards, grocery
Yes.
personnel, every single person who follow the rules, who obey the guidelines, who stayed at home, who washed their hands, who practice
Yes.
physical social distancing is called a hero.
Yes, I totally agree with that. Yes, attorney, doc.
For the last question, Professor David, okay, this is a very beautiful
Question na.
question. Is reinfection of COVID-19 possible?
Okay. Actually, there's no enough evidence to ensure that patients, once recovered from the virus, cannot get reinfected. And currently, we don't have enough evidence to certainly know how long our antibodies would remain in our blood to protect us from reinfection. So the term reinfection should be cautiously used, as it may be misleading. It may be misleading. So as I have heard no, in the 24 oras wherein there is the recovered COVID-19 patient who is also donating convalescent plasma. So he mentioned that he was rejected to donate because his antibodies are depleting despite recovery from the infection. So we have to take good care of ourselves to stay our body fit. We have a strong immune system. Okay, so yeah, we have to be careful in in um in you know trying to communicate, trying to go out whenever we do socialize with other people. So the more we encounter the virus, the more that we don't know what will happen to our antibodies. So we have to bear in mind that people who were infected by the virus develop antibodies and other cellular defense mechanisms that can fight off certain or same virus if they encounter again. But this would be for a certain period only. So
Yes.
let's take good care of our body.
Yes,
Thank
and
you.
of course, to our participants and to everyone, do not be complacent when you encountered other people who have already recovered. They may not be presenting symptoms, but they are still probably infectious. And again, unless and until we have that vaccine, still follow the rules and the guidelines.
Yes.
Okay. That will be the last question for you, Professor David. Thank you so
you.
much.
Thank you very much.
Now, as I mentioned earlier, unfortunately, our second panelist was unable to join us because of an emergency. But to compensate to that, I will introduce to you to none other than our beloved Dean Maria Teresa Rodriguez. Again, Dean Maria Teresa Rodriguez is the current Dean of the College of Medical Technology and Program Head of the Master of Science in Medical Technology Department of the Graduate School. Let me introduce again Dr. Maria Teresa Rodriguez.
Good evening, Attorney Dr. Polido.
Good evening, Dean.
I enjoyed the very energetic, enthusiastic explanation of my favorite professor. I miss her, Professor Geraldine Budumo Dairit. Thank you so much. Okay, now, actually, this is more on clarification, Attorney Dr. Polido. But before that, let me congratulate all our presenters, Assistant Professor Janina Camille Bilago, Dr. Irene Colombano, thank you so much for your time. I know you are so busy, super working more than 12 hours a day. Thank you so much for your time, Doc. And also to Sir Angelo de Guzman. I know that you came from duty this morning. Thank you so much also for joining us. Actually, this is more in clarification, Attorney Doctor, for Assistant Professor Bilago. She mentioned about receptors for the SARS-CoV-2. You know, I've been receiving questions, clarifications, you know, some sharing from our medical technologists. And they said, Dean, what do you think is the main reason that, let's say, for example, there is a COVID positive patient. And then later on, they notice that some organs of the body are being compromised. And I was listening to the presentation of Ma'am Jen, and she mentioned about those receptors. In fact, there's one very prominent receptor. So may I invite, or will I be just, okay, thank you so much, Ma'am, Attorney Dr. Polito. Ma'am Jen, are you here? Still here? Okay. We are waiting for Ma'am Biolago. Well, anyway, Attorney. Yeah, good evening, good evening.
Can you hear me po?
Yeah, yes, yes.
Okay, to answer your question po, Dean, regarding the receptors,
wala pa yung
question for SARS coronavirus 2, the specific receptors are, first is your angiotensin converting enzyme 2, and then we also have your type 2 serine membrane proteases. Now, for the angiotensin converting enzyme 2, it is found in numerous organs in the body, such as the lungs, heart, kidney, and the gastrointestinal tract. But the highest expression of this receptor is found in the lungs, specifically in the nasal epithelial cells, goblet and secretory cells, and ciliated cells. They display the highest expression of angiotensin converting enzyme 2.
Actually, Attorney Polido, I do not have yet the question.
Actually,
Dean, provided the answer.
Ma'am Janina Boliago.
You know, that is amazing.
Yeah, actually, Ma'am Boliago, foresee the question. Ganun siya kagaling.
My God. Because, you know, since my discipline is on clinical chemistry, Ma'am Jen, the question is on the relationship of the SARS-CoV-2 with the other organs. Do we still have here Dr. Colombano? if she also experienced the same observation of the medical technologies. For example, the patient was admitted with the confirmed case of COVID-19. And then after days of hospitalization, they noticed that some of the organs like the kidneys, that is first, and then the gastrointestinal tract are also, developing certain abnormalities. So based on the study that you presented, Ma'am Bilago, are you saying that probably the reasons why some patients initially diagnosed with COVID-19, the heart is of course the lungs are compromised and dysfunctional, and later on, that same patient turn into a dialysis patient? Was it because of the possible reason? Was it because of the angiotensin converting enzyme to receptor, which is also present in the lungs? I'm sorry, in the kidneys.
Ay, Dean, may answer po.
Yeah.
Okay. As a medical technologist, Dean, and based on the literatures that I've provided in the presentation, since ACE2 expression is not limited to the cells of the respiratory system, it can affect other organs since it has affinity to the receptor of the target cell. As mentioned, it is the angiotensin converting enzyme 2. Also, according to the discussion of Dr. Columbano in her presentation, some patients develop diarrhea, and we can associate the development of diarrhea to the presence of angiotensin converting enzyme 2 receptors in the gastrointestinal tract.
Now, thank you so much, Ma'am Bilago. Since you are engaged with the and
Ma'am,
currently,
can I add?
yes, please, Dr.
Yes,
Columbano.
ma'am. Yes, ma'am. Usually po, those patients suffering for comorbidity such as hypertension, kidney disease, diabetes, they are the one who are prone to have complications. So sila po yung nakikita natin na nag-end stage renal disease, heart failure, and acute myocardial infarction. Because of they already have comorbidity prior to COVID-19 infection.
Thank you so
So
much.
they are high risk
Yes.
individual.
Thank you so
Yes,
much.
ma'am.
Dr. Columbano, did you, let's say, encounter a patient admitted with only, because this is the usual question, Dr. Columbano, of some people around us, that the patient was admitted only with respiratory failure because of the SARS-CoV-2. And according to the relatives, the patient has no other illnesses before. Then suddenly, the organs are starting to be compromised, especially the kidneys. Did
Yes,
you
ma'am.
encounter
That's what you call the multi-organ target na sila, ma'am. So let's say it's like a domino effect. From the kidney, magpi-fail din yung heart, and then the lungs, and then the brain. So that's multi-organ damage already, secondary to the COVID-19 infection.
Okay.
But as I said, this is usually common in patients with comorbidity, not in patients who are healthy individuals.
Thank you so much. Thank you so much for that, Dr. Columbano, because that would greatly assist our viewers right now, because I'm sure that is one of their questions. I am healthy.
Yes,
I do not have anything inside me. I just acquired this kind of virus. Will my the kidneys, the gastrointestinal, my heart will also be engaged with this one? Because there are now some articles in the internet, just like the presentation of Ma'am Bilago, saying that the receptors of the SARS-CoV-2 in the lungs are also present in the other organs. So they are saying that probably, Doctora, isn't it? Probably that is the reasons why the other organs are compromised. But coming from a medical consultant in family medicine, Doctora, you are saying that possible, but it is usually those with already underlying sickness and diseases.
Yes, ma'am. Yes, ma'am. That's why we encourage those individuals, especially seniors, high-risk pregnant individuals, to stay at home to prevent acquiring the COVID-19 infection.
Thank you so much, Doctora. Okay.
Thank you, ma'am.
That's all, Attorney Dr. Pulido.
Thank you, Dean. Thank you, Professor Buliago, and thank you, Dr. Columbano. For the rest of the questions that you submitted, guys, we'll try to answer all of them. Just provide an email together with your answers in the comment sections below. Do you still have questions, Dean? None. Okay. So, with that said, this ends our panel discussion. On behalf of the entire team, I would like to thank all those who submitted questions, especially those who listened from the beginning until the end of this lecture. We appreciate your inquisitiveness and participation. We'll now proceed with the presentation of certificates to our esteemed speakers who devoted time, effort, and knowledge in imparting aptly relevant information in the time of SARS-CoV-2 pandemic. The first certificate of appreciation is presented to Janina Camille G. Buliago, RMT, MSMT, for her invaluable contribution as a resource speaker in the Trinity Talk webinar entitled SARS-CoV-2 to NAT or Not, Exploring Nucleic Acid and Antibody Testing as Diagnostic Methods for COVID-19, given this 23rd day of July 2020, Quezon City, Philippines. Signed, Maria Teresa T. Rodriguez, EDD, RMP, Dean, College of Medical Technology, Juliet K. Bukoy, PhD, RSW, Dean, Graduate School, Gisela D. A. Luna, PhD, RN, Vice President for Academic Affairs, Trinity University of Asia. The same certificate of appreciation is also presented to Irene D. DFM, FPAFP. Certificate of appreciation is hereby given to Angelo Christian O. de Guzman, RMP. And the same certificate of appreciation is again given to Geraldine D. Dairit, RMP, MSc, DRDM. And of course, although our okay. Now I will turn over the stage to Professor Nel Sarmiento.
Thank you, Dr. Pulido. I myself really learned a lot from this webinar, and my knowledge on epidemiology and virology was really refreshed by our dear speakers and discussants. So now, as we approach the end of this webinar, we have the Dean of the Graduate School, Dr. Juliet Bukoy, to give us the closing remarks.
Good evening, everyone. Can you hear me?
Yes, Doc.
Good evening, everyone. So I'm so thankful with this webinar, and it's very informative. And I see that there's a lot of challenge that is being encountered by people at this time of COVID. And, it came like a thief in the night. And I think nobody was ever prepared to actually welcome the disease. If you ask me how I actually describe what COVID is, for me, it's a tyrant. It's actually ruthless enemy that we don't know where it is coming from and who it is, who is bringing it, who's carrying it, and so forth and so on. But tonight, in closing, I really like to appreciate the medical technology field and the medical technologists in particular who are actually doing this job, So prior to my appreciation of the medical technologists who are using this technology, I actually wanted to share something. So I wanted to share a little bit of what I know, what the medical technology is actually doing to save lives. Actually, if we talk about, um, am I breaking up? Hello?
You're okay, Doc. You're okay, Doc. Dean.
I'm okay. Okay. So allow me actually to look into the technology that is being used by the medical technologists. And these medical technologies actually enable the early and accurate diagnosis of health problems, facilitating timely intervention and improving outcomes. In fact, innovative products can replace, repair, and sustain failing body functions. So today's medical technology is more advanced. You see, it's more advanced, more effective, and even more, in many cases, it's more costly than ever before. Furthermore, there is an ever increasing demand for high technology diagnostic and therapeutic healthcare facilities and their availability come into conflict with actually other medical necessity, social justice, and cost effectiveness. But actually, this is actually a portion of a article in a journal in Hong Kong that actually appreciate the medical technology and the medical technologies and the medical technologies using this particular technologies. No, so but I really like as a layman, because when you are talking about COVID, you're talking about epidemiology, you're talking about the disease, you're talking about the medical terms. It's very unfamiliar to me, but I really understand how the transmission is, how one can save lives by just staying at home or having protective gear or wearing the mask, as our doctor was saying, or as Ma'am Gigi was explaining about the virus. No, so I really appreciate, but I really value the medical technologists and the technology that they use. First, I can really see and feel the value you do in helping patients save their lives. Actually, improve one's health and sustains healthcare. And your advanced innovative devices and diagnostic enhance the worth of patients. And even you help other health professionals and the healthcare systems and society in general. So that's the first value I see that what you're doing in this pandemic. The second is I actually see you there supporting other healthcare professionals because you give timely and accurate diagnostic informatics, allowing other health professionals to provide clinical decisions that can optimize the patient's outcomes, including the recovery times and complications that may arise in the course of helping the patients. I'm one of those that is very volatile to this type of disease, but I'm very what's this? I take extra precautions to actually not just protect myself and also my family. So the tasks that other professionals may give provide the patients add also value for greater satisfaction, not just for the patient themselves, but as well to the family and the community. So the third is actually I want to appreciate you and look into that your own field. So the medical technology and the medical technologists help citizens to be socially and economically active to improve the healthcare systems and the society in general. Your innovations in the field, which I think it has transcended already from the traditional and more sophisticated gadgets now, help to deliver efficiency and effectiveness in areas of preventing serious and complications of the disease you're talking about, whether it's actually chronic or not so. Or you talk about a carrier, you talk about being positive, or you talk about being negative, or you talk about the symptoms or becoming asymptomatic. So this webinar actually provided an avenue where all the medical field professionals, not just the medical technologies, who are listening right now have actually converged, no? And I am very happy and actually impressed by how this was organized. And I think there are over 200, I think, who are in this particular webinar. And so I like really to at this juncture congratulate especially our speakers. Yeah, so I like to so I don't miss them actually. So I need to read it. Professor Janina Camille Villago, Faculty of the College of Medical Technology, Dr. Irene Columbano, and of course our very own MSMT student and faculty of the College of Medical Technology, Angelo Christian de Guzman, who's also a licensed medical technology. Of course, the sole discussant, Ma'am Gigi, I always like admire you for the courage actually you are doing, and Angelo for helping in this in the testing, no, in the diagnostic that you're doing. It's a noble cause that you do for humanity, and not only those patients, but also ensuring that the safety and protection of everyone to be in this particular stage of not knowing what the disease is all about, when it can be cured, when the vaccine will come, etc. And of course, we miss Ma'am Joy Calayo, who is also a faculty. So, and of course, I will never miss the convener of this webinar, the Dean of the College of Medical Technology and the Department Head of the Master of Science in Medical Technology, which actually I will plug a little later about the MSMT. And of course, the moderator, Dr. Attorney Pulido, who actually is really able to actually give the gist and the synthesis of what the webinar is all about, the NAT or the NOT. So I think we had a very fruitful evening. So I actually congratulate everyone, and we thank everyone for actually becoming part of this webinar. So I just like me, I'm a layman, and I like to understand more about the COVID and how actually I can be a carrier or, you know, become a victim of it. So this is very informative. So congratulations, everyone. And as plugging, so those of you who have not actually taken their MSNT, come to Trinity, and you will see that it is only like Ma'am Tess Rodriguez is saying, that it is our curriculum has actually as that she was talking about. What you're talking about, Ma'am Tess, can you actually help me out? That there's a field that only the Trinity University of Asia is offering it as course. So congratulations, everyone, and I wish you best and be safe. So thank you so much.
Thank you, Dr.
Angelo.
Ladies and
Thank you also. Thank you also.
Thank you. Okay, so ladies and gentlemen, our webinar has finally come to an end. On behalf of the Graduate School Master of Science in Medical Technology Department and the College of Medical Technology, thank you so much for being here with us tonight. We hope you enjoyed this webinar and find it informative and useful. Before you go, please make sure that you answer the evaluation form, as this will be the basis for the generation of the digital certificates. Don't worry, the link and QR code will be provided shortly. Once again, I am Nell Sarmiento, and this has been Trinity Talks, SARS-CoV-2 to NAT or NOT, exploring nucleic acid and antibody testing as diagnostic methods for COVID-19. Thank you and have a good night. Yes,
Nell, I'd like to tell